Just now, I saw a patient and she said, "Doctor, I just came here to get that little slip of paper for surgery. It's a simple surgery, so you just need to write that it's authorized, that everything's fine." "I don't have anything really, doctor. Everything's fine." "Okay, but let's talk a little bit. You don't have anything? No illnesses at all?" "No, no, doctor, everything's fine with me." "All right then. Have you ever had any surgery?" "Yes." "A pacemaker?" "Wait, hold on a second. You've had pacemaker surgery. A pacemaker? So you have a pacemaker?" "I do." "But do you have Chagas disease?" "I do." "Wow, but wait, how come she says she doesn't have any illness at all?" "She has a complex disease." And it's important during a preoperative evaluation, a surgical risk assessment for the doctor, to understand each of the patient's conditions so that they can really analyze what the perioperative risk is. I'm going to explain what that means for this patient and this specific surgery. I'm Christian Souza. I'm a cardiologist. I've been a doctor for 20 years, and I've been running a cardiology practice for over 15 years. Today, we're going to talk about surgical risk. What is surgical risk? Actually, that name, the correct term would be perioperative risk. What does perioperative risk mean? As a doctor, a cardiologist, I'm going to evaluate the patient and the patient's surgery. So I need to know what surgery they're going to have, and I need to, during the consultation, gather information about who this patient is. And I'll try to determine the perioperative risk immediately before, during, and right after the surgery. So the term intraoperative means during the surgery. Perioperative means around the time of the surgery. So the patient's imminent risks close to the surgery, in the interoperative period and in the immediate postoperative period. So why is this important? Because there are many conditions that can become unstable, either because of the anesthesia or due to inflammation caused by the surgery. So, as I said, today, just like on other days, it happens all the time. I did a surgical risk assessment for a lady who at first thought it was just a little piece of paper I had to sign. But in reality, the perioperative risk is much more than just a piece of paper. It's a medical report detailing all the risks that I, as a cardiologist, have identified in this patient. That's why it's important for me to evaluate all of the patient's medical history, the surgeries they've had, the medications they take, all of them: aspirin, anticoagulants, contraceptives, anti inflammatories, every medication the patient uses, so that I can identify any potential changes that might occur during surgery. It's also important during the patient's clinical exam, when I'm examining the patient, to try to identify any diseases, abnormalities, or decompensated conditions. Finally, after gathering all this information, I'll be able to reach a conclusion about the patient's risk. And then, once I understand that there is a risk, I'll start writing. But for that, I often need some tests. And it's important for the patient to bring all the tests they have. And if they don't have all the tests I think are necessary, I, as the cardiologist conducting the evaluation of perioperative risk, need to order certain tests. For example, for the patient I saw today, I had to order an echocardiogram for her. At least she brought me a chest x ray. From the x ray, I was able to identify that her heart is enlarged. Because of that, I suspect she has heart failure. When I examined the patient, I noticed that her leg was swollen. So, besides knowing that she has a condition that isn't being properly treated, I was able, during the physical exam, to identify that she really does have a decompensated disease. In this sense, the patient's risk just keeps increasing. So, before writing the letter, I ordered tests for the patient. I changed her medications. I stopped some medications. I started some new medications for her. I gave her instructions, and I asked her to come back to my office. So, after all that, when she comes back, I'll be able to assess whether she's compensated, if she's clinically better, if she's stable. And then that's when I write the letter. Assessment of cardiac risk. The patient has, for example, in her case, Chagas disease, hypertension, arrhythmia, and a pacemaker. However, she is compensated, she is clinically stable, and she is taking the following medications. Respiratory assessment. That's not her case, but just as an example, the patient is a smoker. She has chronic obstructive pulmonary disease, pulmonary emphysema, is taking these medications, and is experiencing decompensations. I need to write that down. The patient has already had a stroke, is on anticoagulants, has diabetes, and uses insulin. All of this affects the risk, sometimes of bleeding or recovery or infection during surgery. So that's why, once again, the cardiologist, calm, collected, and patient, needs to review all the illnesses, all the medications, all the tests, and stabilize the patient so that the surgeon can then perform the surgery safely, not just for themselves, but especially for the patient. And by performing this safe surgery, the patient will have a good perioperative recovery. So that's what I wanted to share with you. While you go over all this information we've discussed and figure out what's important to you, remember to like this video and share it with people who might benefit from this information. And remember, health is more than just looks, it's about performance and longevity. And as a cardiologist, I'm concerned about the longevity of all my patients. And you, as a doctor, if you are a doctor, should be concerned about this too. Big hug and see you in the next video.